Should I read the question again?
Yeah, please again. Sorry.
Okay, so the question says the 46-year-old woman has a history of progressive painless diminution of vision in the right eye for approximately 1 year. Formal visual examination revealed a visual acuity of 20/200 in the right eye and 20/20 in the left eye, with a right inferior temporal field deficit. And fundoscopic examination revealed primary optic atrophy in the right eye. The rest of the neurological examination was unremarkable. Question number 1 says describe the pertinent findings on the MRI. And on the screen we have 3 views of the MRI. We have a coronal view, a sagittal and axial view. The MRI is gadolinium enhanced. The coronal view shows a vividly enhancing mass in the Sellae region. Lesion seems not to be extending so far superiorly to the hypothalamic and third ventricular regions, and doesn't seem to be extending laterally to the ICAs. Neither does it seem to be extending inferiorly into the sinus, the sphenoid sinus. On the sagittal view, it's still restricted within the Sellae with no posterior extension towards the prepontine systems or the brainstem, and also barely any anterior extension into the frontal lobes. And in the axial view, we see that the mass is almost in the midline, but a little bit more oriented towards the right. There is some little bit of involvement of the posterior aspects of the base of the frontal lobes, but it's purely extraaxial. And the cisterns, the perichiasmatic cisterns seem not to be involved, especially the right and posteriorly. So our answer says the MRI shows an enhancing duro-based lesion arising from the tuberculum Sellae. It's hypointense on T1, though we don't have those T2 images, but it says it's hyperintense on T2 with bright contrast enhancement. It arises in the midline, slightly centering to the right, where it displaces the right optic nerve superiorly. I think this is the arrow that we see on the coronal cuts. There is no significant lateral extension, nor does it encase the right ICA or the anterior cerebral artery superiorly. There is no extension into the right optic canal or cavernous sinus involvement. There is no evidence of brain edema surrounding the tumor. MRI findings are in keeping with the diagnosis of a tuberculum Sellae meningioma. Maybe a little discussion about question number 1. Maybe the other thing is, if it's not a tuberculum Sellae mass, what else could it be? And the differentials that I could come up with are a pituitary macroadenoma. And what would differentiate a pituitary macroadenoma from this is the fact that the pituitary macroadenomas arise from the pituitary gland itself or the stalk, and it usually expands the Sellae. This mass has kept the Sellae size the same. Then we can have craniopharyngiomas, and craniopharyngiomas are most of the time having a cystic and solid components with calcifications. Most of the time they extend superiorly to involve the third ventricle and hence cause third ventricle, and then the foramen of Monro to cause obstructive hydrocephalus, and they may have mass effect on the surrounding structures, but still there is usually no edema, just like in the meningioma. Then we can have the dermoids or epidermoids, the optic pathway gliomas, hypothalamic hamartomas, though those will be mostly suprasellar, and then vascular lesions such as aneurysms. I don't know if anyone has any addition about question number 1 or corrections, subtractions. Okay. So question number 2 says, what are the most common modes of presentation of this tumor?
I think Dr. wanted to make a contribution.
Let me.
Yes.
Okay. Thank you very much for this thing. I think
your network is breaking. We cannot hear you very well.
Question is how do we differentiate a tuberculum? Am I audible now? Can anybody hear me now?
We can't get you properly.
Hello, I don't know if I'm audible now. Good evening.
Yes, we can hear you now.
Yes, so I think a common exam question is how to differentiate a tuberculum Sellae meningioma from an olfactory groove meningioma. That's a common exam question, and I think part of the response, part of the answer to that question was actually provided in that first paragraph. I think is in how they displace the optic nerve. Now the tuberculum Sellae meningioma usually displaces the optic nerve superiorly, unlike an olfactory groove meningioma, which causes an inferior and an inferiolateral displacement of the optic nerve. I think is a very important point to note. It's a very common exam question. How? Because those meningiomas are similar. And then another difference between two of them is that an olfactory groove meningioma is almost always midline situated. It is not sided to any part. If we look at this image, the axial cut of this image shows that this lesion is mainly right-sided a bit, tilted to the right. An olfactory groove meningioma is almost always eccentric on an axial cut. So I think those are the two points I want to raise on this first paragraph. Thank you very much.
So you meant concentric, right? Not eccentric.
It is on the center. The olfactory groove is almost always, I think eccentric should be the word, as in centralized. It does not, is not one-sided.
No, maybe concentric. If you say eccentric, that means it's towards one side.
Oh, sorry. It's on the center. It's mainly almost always on the center, as in it's one-sided.
Okay.
But I think the most important way to differentiate olfactory groove and tuberculum Sellae, which is a common exam question, is how they displace the optic nerve. Tuberculum Sellae displaces it superiorly, olfactory groove displaces it inferior laterally. So I think those are the points I want to raise. Thank you very much.
Okay,
and we
thank
can
you for the
remember
addition.
We can remember that easily, like, you know, how we always have mnemonics. So Sellae superior, so easily. So Sellae superior. Okay, thanks.
Okay. Okay, I think also differentiating the OGM from the tubercular Sellae can be done based on the clinical presentation of the patient, whereby in the OGM, you'll have olfactory symptoms presenting first. Then as the tumor grows bigger and also extends posteriorly, you'll have the visual deficits coming in, and then the tuberculum Sellae meningioma will give you those symptoms the other way around. Because starting from the side of the optic apparatus, so you have visual deficits first. As it grows bigger and anteriorly, then the olfaction will be affected. And the type of visual dysfunction that you get in the OGM is most of the time the bitemporal hemianopsia, because it's in the center, while so it compresses the optic chiasma in the center. While this tumor, since it's growing towards one side, you may have a complete visual loss on that side, since it may be compressing the nerve itself before it goes to the chiasm.
Sorry, let me just come back on that. Apologies. I think the one for olfactory groove meningioma, you see the classical Foster Kennedy's. You might see the classical
Foster Kennedy syndrome.
Yeah, so in that case, what you have is unilateral visual loss. More likely where the on the side where the compression is located, and then you have some papilledema on the contralateral side, where there's transmission of pressure from through the brow attachment of the optic nerve eyeball. So you have papilledema on the contralateral side. But visual loss is unilateral, and then of course, you have anosmia, and then lateral visual loss, and then contralateral papilledema. So I think that's one thing to note. So it may not necessarily be for the tuberculum Sellae. I think that's where you have the compression, direct compression of the chiasm, giving you the bitemporal hemianopsia. That's more likely to occur with tuberculum Sellae, considering the fact that the site of origin is directly related to the optic chiasm, where the chiasmatic groove on the sphenoid bone. So that's my thoughts on that. And then, the pattern of visual impairment has already been talked about. Yeah, thank you.
Thank you. Question number 2. What are the most common modes of presentation of this tumor? And the most common presentation is progressive painless visual loss, which may be unilateral or bilateral, either a homonymous or a bitemporal hemianopsia. Patients with larger sized tumors may also have endocrinal dysfunction, either on the basis of compression of the pituitary stalk, in which case they may have a panhypopituitarism, or the gland itself, and they may have a pituitary dysfunction based on the cells that have been compressed. That is the most common presentation, progressive visual loss. The less common modes of presentation would be persistent headaches due to dural traction or seizures. Any additions on number 2? So clinically, those tumors may be differentiated from olfactory groove meningiomas or tuberculum Sellae meningiomas initially. Since tuberculum Sellae meningiomas initially present with visual dysfunction as they grow larger, I think we've talked about this statement already, that the tuberculum Sellae meningiomas will initially present with visual dysfunction, but as they grow larger, they can affect the olfaction. Then the olfactory groove meningiomas will initially present with olfactory dysfunction. Then as they enlarge, they affect the vision. Question number 3, what are the options for management of this tumor? And
okay, sorry, I have an addition here. I don't know. Maybe this addition should be reserved when we go to olfactory groove meningioma. I know we cannot talk about olfactory groove and tuberculum Sellae meningioma without talking about Foster-Kennedy syndrome and pseudo-Foster-Kennedy syndrome. But I think those syndromes are usually elaborated in olfactory groove meningiomas. But given that a close differential of olfactory meningioma is tuberculum Sellae meningioma, I think it's also important for us to know about Foster-Kennedy syndrome and pseudo-Foster-Kennedy syndrome, because that's the commonest syndrome that is associated with these meningiomas in this region. That's lesions in this region. These olfactory groove and tuberculum Sellae. But since olfactory groove meningioma may still be a topic we'll still look at later, maybe we'll talk about it when we get there. I don't know what we think.
Yeah,
I think
next
if you want to talk about it now,
tomorrow
you can talk about it briefly, then we shall expand on it when we talk about the OGM. That's my thought. I don't know what everyone else thinks.
Yes, I agree.
So go ahead, Dr. Azode. You can just go ahead. I actually mentioned
Okay.
Oh, okay.
Okay, so so for Foster-Kennedy syndrome is a triad of anosmia, which is from what's his name? Which is from the first nerve involvement, and then there is also a ipsilateral atrophy, and then contralateral papilledema from a ipsilateral optic atrophy and contralateral papilledema. That's the Foster-Kennedy syndrome. It's a triad of anosmia, ipsilateral optic atrophy or visual loss, and contralateral papilledema from from perilesional edema from the tumor. And it usually occurs a Foster-Kennedy syndrome usually occurs in the presence of a space-occupying lesion. That's one of the difference between a Foster-Kennedy and a pseudo-Foster-Kennedy syndrome. Pseudo-Foster-Kennedy syndrome can occur from things like any optic nerve involvement, like optic neuritis, inflammatory conditions involving the optic nerve, optic neuritis, and the rest. I think there's another difference between two of them, but I think I'll read it up for the olfactory groove meningioma when we'll talk about it, so I can elaborate more on how to differentiate between Foster-Kennedy and pseudo-Foster-Kennedy syndrome. But Foster-Kennedy is just a triad of anosmia, ipsilateral optic atrophy, contralateral papilledema. Thank you, sir.
Okay. I have a question on Foster-Kennedy syndrome. What causes the contralateral papilledema? And then I know the ipsilateral atrophy and the anosmia is mostly mass effect from the tumor. But the contralateral papilledema, are we saying almost all the time they'll have increased ICP?
It's not fully explained if all the time they have increased ICP, but the explanation for the contralateral papilledema is just the pressure, perilesional edema from the tumor exerting a pressure on the retinal vessels, thereby causing an engorgement of the optic disc and the rest, thereby giving
I think what
giving
happens,
the picture of a papilledema.
Dr. Mike, I think what happens, right, is that it's you know that the optic nerve carries a dural attachment, right? So it's
Yes,
like
sir.
a direct continuation of the brain. So it carries a dural attachment around it. And the dural attachment is unyielding, right? So, and then it attaches directly, that dural attachment attaches it directly to the optic disc in the fundus of the eye, right? So it means that any pressure within the intracranial space can directly transmit through the optic nerve and be represented as papilledema on the optic disc. So what happens is that and it's non-compliant. So what happens is that if there's a pressure on the contralateral optic nerve, so this time anyway, you call it the if you're talking about Foster Kennedy now, you call it the ipsilateral optic nerve. So the site where the tumor is, if there's pressure, it displaces CSF towards the contralateral side. And when the pressure continues to increase, you have pressure build up within the optic nerve sheath, and that results in the edema. So
Thank you,
that's
sir.
actually the basis, yes, for the papillary edema you see in that case. So that's what happens with the Foster Kennedy. Yeah. Thank you.
Thank you, sir.
Hello? There's another theory that talks about ischemic changes in the contralateral side.
I can't hear you, Dr.
Hello?
Saskiri. Can you come closer to your mic?
Hey, it's Dr. Antege speaking.
Antege, please, can you come closer to your mic? Okay, go ahead, please.
Okay, so what are the options for management of this tumor? Observation for small tumor found incidentally with no visual disturbance, surgery, and radiation therapy. What are the indications for surgery? Progressive diminution of visual loss is the main indication for surgery. Other indications are persistent headache, mass effect, and surgery is rarely done in case of seizures alone, and endocrine dysfunction alone is uncommon and not a common indication for surgery. Is primary radiosurgery an option in treatment of this tumor? Due to the intimate proximity of the tumor to the optic nerves and the chiasm, which usually overlie it, the fact that visual loss is a common presentation, radiosurgery is usually not considered a primary line of treatment for this tumor. And if there were extension into the sella, radiosurgery to the gland could lead to delayed hypopituitarism. However, after adequate tumor removal and optic nerve decompression, if there is a residual tumor either within the cavernous sinus or adjacent to the internal carotid artery, then radiosurgery can be considered as an option. And this is especially if the pathology did not say higher grade or demonstrates growth upon follow-up imaging. And in patients with severe comorbidities where surgery is a high risk, then fractionated radiosurgery may also be considered as a primary option. Then the next question is, what's the goal of surgery? And the goal of surgery is usually safe gross total resection with preservation of all the neurovascular structures and reversal of the visual and endocrine dysfunction. However, this is not always possible, and the goals have to be determined on a case-to-case basis, depending on the age, on the nature of presenting symptoms, size, and radiological features, such as extension of the tumor, vessel encasement, especially if it extends laterally into the ICAs, and the cavernous sinus, or based on the intra-op findings. Next question. Anyone has an addition? Okay, next question. Enumerate the preoperative investigations specific to this pathology in preparing this patient for surgery. And like any surgical case, we have to get a detailed history and physical examination of the patient. Most important is to determine the level of vision in the eye, both eyes, normally we send the patients to an ophthalmologist so that they have a complete ophthalmic evaluation, which includes a visual acuity, a visual field testing, and a fundoscopic exam. The fundoscopy will tell us about the status of the disc and also the status of the optic nerve itself. Just like we've said that we may have a papillary edema due to increased ICP or atrophy due to compression of the nerve. Because part of the approaches to this tumor is an endoscopic approach, it's important to have the ENT evaluate this patient to rule out any sinusitis, especially in the sphenoid air sinuses, or any masses in the sinuses. And during this evaluation, we want to know the anatomy of the sphenoid air sinuses. Basically, how well pneumatized is the air sinus? The better pneumatized it is, the better for our approach if it's endoscopic. I think, like in this case, we have a very well pneumatized air sinus. The pneumatization is classified. I came across something from it was in Greenberg. There are about 4 types. We have the we have the Concord type, whereby there is a very small area, almost no air cavity in the sinus. Then the Preseller is the sinus cavity is anterior to the Sellae. And then we have the Sellae type, which can be complete or incomplete. And in this patient, we have a complete Sellae type of pneumatization. So still during our assessment, we need to do a full pituitary hormonal and biochemical profile to detect any preoperative hormonal dysfunction, which may need to be optimized before surgery. The most important hormones to check here are the cortisol, the thyroid function hormones, and these have to be optimized before surgery. Otherwise, we may have catastrophe intraoperatively. But still, we need to do all the other hormones like the prolactin, the growth hormone, because it's going to help us during patient follow-up. We need to also do the other blood tests, which have not been mentioned here, like a full hemogram. Need to know the coagulation status of the patient, what blood group, and cross-matching, patient serology. And we also book blood. Then in terms of imaging, MRI of the brain with specific focus to the Sellae and the suprasellar region to delineate tumor extension, especially its lateral extent, and the casement of the vessels, displacement of the pituitary stalk, and presence of brain edema has to be done. And if an endonasal approach is being considered, a CT with thin slice axial coronal reconstructions, usually I think to evaluate extent of hyperostosis and study endonasal anatomy is very helpful. Then we must have a pre-anesthetic assessment to ascertain the fitness of the patient to surgery. And now, next question is, what are the different approaches that can be used to remove this tumor? We have transcranial open approaches, and transsphenoidal endoscopic approaches. The transcranial approaches, we can have a bilateral, usually reserved for large-sized tumors above 4 centimeters, and they can be a bilateral subfrontal approach or bilateral transbasal interhemispheric translaminar terminalis approach. The bilateral subfrontal approach, I think, is goes between the two lobes. It's a subfrontal approach, but you have to work between the two frontal lobes. However, the transbasal approach, you work from the skull base, just like the OGM approach. Then you have to open the lamina terminalis, then onto the tumor. And the unilateral approaches are basically for the eccentric tumors. You have the unilateral subfrontal, the unilateral subfrontal plus orbital osteotomy, peritoneal transsylvian approach for the orbitozygomatic, then supra-orbital mini craniotomy of the keyhole. And we have the transsphenoidal approaches, can be microsurgical transsphenoidal surgery or the pure expanded endoscopic. The diverse growth patterns of this tumor may require that a variety of approaches be considered to provide an optimal surgical management. I think this is a statement that we are usually told that when we are going into any neurosurgical case, you must have plan A, plan B, and plan C, all well laid out before you start the case. So if plan A fails, just switch to B and C. So we must have a variety of approaches considered for such tumors. What are the advantages and disadvantages of the endonasal endoscopic approach? Advantages are that it has a more direct approach to the midline central skull base pathology. And if we go via the transcribriform, transplanum, transtubercular, transclival corridors, we shall have access to the entire central anterior skull base. Though this will require more bone work, and more bone work comes with more opening of the skull base. Hence, sometimes you may have to do some skull base reconstruction. And then the risks of CSF leaks may come in later. Then minimal or no brain retraction is required during this approach, and it provides an early en route devascularization of the tumor. On the other hand, the transcranial procedures often require working over and around the optic nerves and the chiasm. But with an endoscopic approach, there is no manipulation of these structures. Then it allows for visualization and careful dissection of the superior hypophyseal and anterior cerebral arteries, provides a panoramic view of the relevant anatomy with improved illumination and better cosmetic results. Its disadvantages are that it's a technically challenging approach with a steep learning curve. Sometimes we may have to involve the ENT surgeons to do the nasal dissection to make the flap all the way to opening up the air sign, the sphenoid air sinus. And there is restricted maneuverability and workspace, making instrument manipulation difficult. There is lack of binocular vision during this approach, and CSF leak remains a significant challenge, requiring complex reconstruction techniques. Any additions on the management of this patient and the different approaches and the cause and pros? Okay, the next question is briefly discuss the important technical nuances in removal of this tumor endoscopically. And they've given us some images down here, which show the step-by-step approach to these tumors. They've started from the superior roof of the sphenoid. So we have already done the nose work. Now we are at the what? At the base of the at the roof of the sphenoid air sinus, which is the base of the sella. The initial harvesting of a vascularized nasoseptal flap, which is a major element in reconstruction, is performed. Then a wide exposure of both lateral and medial optic carotid recesses, the paracellar carotids, optic prominences, planum sella, and clivus. I think this is an important step. We need to open the whole floor of the sella and also the posterior part of the base of the anterior cranium, so that we have adequate visualization of the neurovasculature to avoid inadvertent damage during the later steps of the procedure. The devascularization of the dura is done with coagulation of the posterior ethmoids, and these posterior ethmoids are the main source of blood supply to these planum, the tuberculum cella meningiomas. So an early coagulation will reduce on the risk of bleeding during the further steps, and we also make the surgery a little cleaner. Use of bimanual microscopic technique, internal debulking of the tumor, and careful extracapsular dissection. I did not understand this point. I don't know how we do the bimanual microsurgical technique. I don't know if anyone can help us understand it better. Okay, the initial dissection of the anterior superior margin.
Sorry. I'm not talking about that, but I just want to lay a clear. I think these things they are talking about is like the critical steps in endoscopic anterior skull-based surgery. So what they are talking about is immediately you start. So the first few steps is you gain your access into the endonasal space, and then you raise your nasoseptal flap, because the aim is that the nasoseptal flap is essentially important for you to be able to do a repair of the skull base, that's the floor, to prevent dural leak. So you need to raise a nasoseptal flap. So that means that the part of the septum, you make a cut, take a cuff of the septum, and then the nasal mucosa, and then you denude it off the ostium. So that flap you've raised, you have to pedicule it. It has to be, you have to be careful with it so that it doesn't get devascularized. And then you keep it carefully retracted in order to be able to have adequate view. Now, the second point, what they are trying to talk about there is that you need to have adequate view. That means you need to drill the floor of the sella to have adequate view of the optical carotid recesses, because the carotid prominences help you to be able to clearly delineate the location of the carotids, so that you walk in between the carotid prominences, and you don't go too lateral to the sides in order to avoid injury to the carotids. So that's an important thing here. And then you stay along the midline, in between medially, and then you can, since for this is a tuberculum Sellae meningioma, of course you'd want to look behind. The aim is to start from behind, and then you now look upwards until you identify the sphenoid ostia, Then you drill, you break the vomer, you're within the sphenoid sinus, and then you now look upwards to where you identify towards where you identify the base of the tuberculum cell. Then you drill till you can clearly see the tumor. You now till you breach the cellar floor. And then you see then you drill also to expose. That's when you do your anterior access. You drill, and then you expose the tumor, and then you now do your surgery. So you start from down. You start from posteriorly. Then you identify the ostium. You break the vomer. You identify the two carotid prominences on both sides. Then it will lead you upwards. As you go upwards within this cellar, you then break the floor, and then you go more forward. It will lead you to the tuberculum of the cellar. Then when you get to the tuberculum, you drill, and then you identify your tumor, and then you break. So I think that's my understanding of what they are saying. So you have to have adequate exposure, and then identify these important surgical landmarks. Yeah, I think that's that. Thank you.
Thank you very much, Dr. Abbas. Let me just quickly add a very common differential of cellular region tumors is an internal carotid artery aneurysm. I remember my first time when I was assisting my oga in theater because we usually do an open approach, though sometimes we invite a surgeon from Lagos to come and do transsphenoidal in our center. But my oga usually trained us to do an open approach. So I remember when we are doing a bifrontal craniotomy, with a subfrontal approach for a tuberculum Sellae meningioma. So I think when my oga exposed, he asked for a syringe and a needle, and he aspirated. And the question he was asking me was, why am I aspirating? And I couldn't answer the question. So it was later he told me that a very close differential of lesions around the cellular region is an internal carotid artery aneurysm. So whether you are going through an open approach or you are going through an endoscopic approach or a microscopic approach, you must mention precaution to prevent harvesting a potential internal carotid aneurysm. Open approach, you want to aspirate and be sure that it's not blood you're aspirating. So you know that this is actually a tumor and not an anomality of a blood vessel, which in this case will be an internal carotid aneurysm, given that they are very close to the clinoid process. If you are going endoscopic or endonasal microscopy or endoscopic endonasal approach, when you finish the nasal phase of the dissection, finish the sphenoidal phase of the dissection, you have to use a Doppler scan to scan and localize the internal carotid arteries. Usually you will hear their pulsations. The times I've seen transsphenoidal done, the surgeon always makes sure he hears the pulsation of the two internal carotid before he drills, the posterior wall of the sphenoid to now get to the tumor. If not, if you drill without doing that Doppler scan and be sure that you are hearing the carotid's pulsation very loudly in theater and you go ahead to drill, you may cause an inadvertent injury. Unfortunately, there has been a case where we had an inadvertent injury to the carotid and the surgery had to stop at that level. It just has to pack with with subcutaneous fat. He harvested from the abdomen, packed with his T-cell glue. And then we closed up the patient. We just came out and then had to come back later after about 2-3 months to do an open approach to take away the tumor. So that was just my addition to this. Thank you very much.
Thank you very much. Beautiful contribution. Yeah, it can also be an ACOM aneurysm. Yeah, it can also be an ACOM aneurysm. So, yes, this is a very common question also in my center. The question he asked you, and their question are, what are the differentials of aneurysm in the cellular aneurysm? Yeah. So first differential, of course, is internal carotid artery aneurysm. It can also be an ACOM aneurysm. So that's another one. Dr. Gundu, I think there's one more differential, right? I don't know if you remember it. I always forget, but there's another, the clinoid. So it could be a communicating segment or a clinoid segment. I can't remember, but sorry, I said clinoid segment aneurysm or an ACOM aneurysm. I can't remember.
What of the plantar sphenoidea?
As in planum sphenoidal meningioma?
Yes.
Yeah, it's possible, yes. But what we're talking about now is we are talking about the different aneurysms that can be located within the sella and may provide the basis for initial test aspiration before you go ahead to drill the not to drill, rather it's to open the dura, the cellar
Yeah,
floor.
for
So
open surgeries, test aspiration. For endoscopic
even
endonasal
endoscopic.
transphenoidal, you use a Doppler.
No, the two things, yes. But
Uh,
even in the endoscopic, they still test aspirate actually. Some still do test aspirate.
okay.
Even in the
Sorry
endoscopic.
to
Especially when you don't have a Doppler, they
sorry
do.
to interrupt. I mean, this syringe, is it to puncture on the mass and be sure it's not an aneurysm?
Yeah, what
Yes,
my Oga did was yes. You have to
what they
aspirate because
do.
it's a 2
But
mil syringe.
is that not quite invasive on if it's an aneurysm?
No, in fact,
No,
this is even Oga Mahmoud that first did this thing, that first asked us this question. We used to do a couple of endoscopic transphenoidal in Abbott then when he was still on ground. So he was like, okay, so there was a time actually in Abuja that they opened and it was an aneurysm. You understand? And it was catastrophic. So they had to just package the patient and all that. And then when they now went back,
No, I get,
the
Dr.
radiologist
Abbas.
came back and
I
told
know
them
there
go.
is a difference between practices and things that are supposed to be. I'm not negating anything. We're just discussing generally now, because let's say you have pre-op imaging to say if something is an aneurysm or not, and you go in and you will start putting needle into an aneurysm. I don't know if it's
No. Usually, what happens is this: preoperatively, you may not be able to have a classical, you may not be able to get a definitive diagnosis of an aneurysm preoperative.
exactly.
Yes. So what usually happens is that it's now became a routine for most of them that because of that challenge, they just test aspirate
okay.
before they open the dura,
Exactly.
before they do their incision to start their decompression. So just test aspirate just to be sure. And they use a small gauge needle to test aspirate.
Exactly.
Yeah. Yeah, so that's the information I have, and I know I've heard this from a couple of consultants, and even from both sides of Niger. So I know it may be a question someone may be asked, especially when you're discussing management of pituitary endoscopic management of pituitary macroadenoma. They may ask, even open actually, they may ask that question. So that's it.
Or in places where you have ultrasound, as you said, and all
Doppler,
that.
intraoperative Doppler, but what it concern you, you don't have any issues. You just do your Doppler move. Yeah.
Yeah, with the Doppler, you will hear the pulsations of the internal of the if it's an aneurysm, you hear the pulsations. You know that this is a blood vessel. Yeah.
I have a question. When we are opening up the flow, what is our lateral extent? Do we open to expose the ICAs?
No.
Or we are not supposed to expose the ICAs?
I think that depends on the extent of the tumor. Is it involving carotid sinus extension or not? If it extends into the carotid sinus, well, we've heard of people, the Robert Spetzler's proteges and the big men in the US that even open as far as exploring via the endoscopic route, exploring the cavernous sinus. So
Yeah.
it's possible they open and explore the cavernous sinus, so to remove as much tumor as they can. So it all depends on the extent of the tumor, but most of the time you want to avoid the carotid, stay in the midline, avoid the carotid prominences as much as possible, and then resect your tumor and go out.
Yeah, just a comment on this. One of my teachers, I'll mention his name again, as mentioned earlier, Professor Mahmoud, usually advised that it shouldn't go beyond 1.5 centimeters from the midline. And usually your blade should face, you should start from outward in to prevent excessive excision or incision rather beyond your control.
Okay. So after resecting our tumor, we must close, and we do, after meticulous hemostasis is achieved, we do a multi-layered reconstruction, which concludes the procedure. We may use synthetic dural grafts, we may use biological glues, we may put a abdominal fat, and most importantly, we have to put back the pedicle nasal septal flap that we had raised earlier during the nasal part of the dissection. All this is to try as much as possible to prevent CSF leak. I think some people go ahead and put plates depending on the size of the defect, especially if you've dissected quite more anteriorly and also more posteriorly if there's an extension towards the clivus. I've not seen that being done. Most of the time we just put our synthetic synthetic dural patch, the G patch, then we put glue. We may or we may not put the abdominal fat, but then we have to put back the flap. And then the question I have here is use of the lumbar drain. Do you guys use this lumbar drain routinely or only when there is a CSF leak? A couple of times we've had patients who have had CSF leakage in the first few days post-operatively, to an extent that now one of our bosses now routinely uses the lumbar drain. I don't know your experience on that.
Okay, to be honest, in my center, we have access to the lumbar drain, but we have never used it. We usually just make sure it's available in theater. And the aim of our use of lumbar drain is for two things, actually. First, intraoperatively, it offers you the ability to instill saline so that you can actually stimulate depression, allow the saline, the suprasellar system, CSF within the suprasellar to push down the lesion so that it can descend into the cellars for you to be able to have adequate tumor resection. That's one. Two, it helps you to let out CSF in patients who have CSF leak post-operatively. So those are some of the advantages of the lumbar drain. But
I didn't get the first point.
Yes, what's the advantage of having a preoperative placement of a lumbar drain is that when you are intraoperative, when you're operating, right, you know there's a diaphragma sellae, and just over it you have the suprasellar system. So
yeah,
if you are operating and then you need the tumor because maybe there's some significant suprasellar extension and you need the tumor to push the tumor downwards into your operating field, right? You can instill some saline by your lumbar drain to stimulate, to fill up the subarachnoid space and push down that tumor down into your field.
Mind you, Dr. Tege, that's for suprasellar masses.
Yeah, I'm just saying yes.
Just so he doesn't think it's for this also.
Oh, okay. No, it's not for tuberculum sellae. Because tuberculum sellae meningioma, you don't need to do much because you are going an anterior skull-based approach is what you're doing. So you don't need to drill that significantly. But for supercellular lesions, actually, you can instill saline to push down the lesion, especially for pituitary microadenomas. But for tuberculum sellae, majority of times, except if it's very huge, majority of times your lesion, your tumor is just immediately below you when you drill, so you can easily resect. Except if there's significant lateral extension, then maybe you have to do radio surgery subsequently. Then the main aim of the lumbar drain actually is for postoperative prevention of CSF leak, which you can actually do by letting out some CSF. Sorry, management actually, not prevention. Management of CSF leak, yes. Thank you.
Did any one of you come across a grading system of tuberculum sellae meningioma, the preoperative grading system that will help determine the surgical approach and also plan for the risks? There's a grading system that has been used, but I don't remember it. But it has 3 levels: tumor score, canal score, and artery score. It is used for determining the preoperative surgical option, whether you're going to use the endoscopic approach or transcranial approach, and also to determine whether you are going to, how prepared you are to the risk of what? Damage to the vasculature and also damage to the optic nerve and chiasma. But the grading system, I don't remember the clear details, but it is there. If we go back to read, we should read about the grading system of the preoperative grading system for tuberculous sellae meningioma. It is there.
Okay, thank you. We'll check it up.
Or is it the one that talks about tumor size or encasement of the optic canal? I'm sorry, encasement of the ICA and optic
Yes,
canal.
and also the canals, the encasement of the ICA, the tumor size, and also the canal in the canal. Yeah.
TOE, toe, optic tumor, optic canal, and encasement. TOE.
Is it the McDermott and colleagues? Is that one?
What's that? Okay, if you know, we can share it on the page or something. I didn't hear you.
Yeah. I'm just searching. I'm on Google, so I saw something about McDermott and colleagues proposed a grading scale that considers tumor size relationship with optic nerves and relationships with adjacent arteries. So I'll share it on the group. Is that the one that you're speaking of? Is that?
Yeah. It's the one, I know it's TOE. I know I've seen it.
It's called McGill McDermott.
Yeah, that one. That is the name. That's the grade I'm talking about. But
Okay.
I don't remember the details. But that's the grade. That's the name.
Okay, I'll share it on so we can go into it.
Okay, I think I just saw something online. So please share the details you have. I just saw something. I'm not very.
I just searched for that. Okay.
Thank you. Dr. Saskiria, please proceed. I think Saskiria is out of the room, or is it still here? So I think our presenter dropped off. Affairs, Dr. Ali.
Hello, yes.
Contribution.
Nana, I'm just
Hi.
listening to everything. Nana, it's very good discussion going on. Actually, I read this topic from here and from Greenberg, but not from the other books. But few of the things still I am also grasping. 2, 3 new points also came. So I'm just listening to it. Very good discussion. Just continue. Huh?
So actually, there is a book on mengiomas because my guy usually is a kind of like strict man. So they usually ask questions a lot during surgery. So anytime we have a meningioma case, I go to that break it off. The book is called MFT Meningioma because meningioma is the most common brain tumor insect. I don't know how people in the experience. So I will recommend the book. In addition to the Greenberg, another textbook of neurosurgery, meningiomas actually have a book dedicated to them. Every type of meningioma is in that book. Or fact, tuberculum, Sellae, petrocliva are in that book, and they were well treated. So it's Almefti meningiomas. That's the name of it. So I always read it. I always read it whenever we have a meningioma case. I go to that book and read it very well. Yeah. Thank you very much.
Thank you. All right. All right. So I think Dr. Saskiri went offline, or is he back? Dr. Saskiri, are you back?
Yeah, sorry.
Yeah,
And I didn't notice.
Oh wow.
Yeah. I don't know where I went off from.
Okay, so we stopped where we were talking about the classification of tuberculum, Sellae, meningiomas. Where we stopped, we actually were talking about we've not gone beyond the intraoperative what do they call it now? Intraoperative nuances. Hello.
Yes.
So Sanskrit. Yeah, so we're still on the intraoperative nuances. That's on 10. So we're on the second page, visualization of the key neurovascular structures and coagulation.
Okay. What? Okay. No. We had finished that one, I think.
Okay.
We were on complications, not so.
Complications, yeah, we're done. We did multi-layered reconstruction, yeah, we're done with that. Yeah.
We can do, okay, so the intraoperative complications, we have vascular damage to the surrounding vessels, like the hypophyseal artery or perforators from A1. Then attempts to remove the tumor adherent to the ICA may also cause vascular injury, and manipulation of the pituitary stalk can result in transient diabetes insipidus. Inadvertent manipulation of the optic nerve or its blood supply can cause visual deterioration, which most often is transient but can also be permanent. Postoperatively, CSF leak is the most common complication. However, its incidence has reduced due to use of multi-layered closure. Meningitis, which can occur as a result of CSF leak. Pneumocephalus, secondary to CSF leak. Electrolyte and hormonal imbalances, especially DI. And last question, discuss briefly the radiological and functional, in brackets, visual and endocrine outcomes of the endoscopic excision of tuberculum Sellae meningiomas. Among the case reports and small case series published in literature in the last decade, about 200 patients, the gross total resection rates vary from 54 to 100%, with an average of 81%, and CSF leak rates range from 15 to 20%. Endocrinological complications include transient and permanent DI, with incidence rates of 2.6 and 1.9 respectively. Postoperative hypopituitarism has occurred in 3.3%. Then in a meta-analysis comparing the open versus the expanded endonasal approaches, visual improvement was much higher in the endoscopic cohort, up to 73.5%. And CSF leaks were higher as well, up to 21.3%. The endoscopic approach yields higher visual improvement and lower deterioration rates. And although postoperative CSF leaks remains a significant problem, the incidence has reduced. So in conclusion, the removal of the intradural skull-based meningiomas remains controversial, and a clear understanding of the limitations of an endoscopic approach is very important and helps to guide patient selection for the use of this technique. And that's our last question.
Thank you so much. Thank you very, very much. Beautiful. I don't know if you have anyone who has any contributions, questions, or anything we want to say. It's 10:19. We've spent exactly an hour and 9 minutes. Any questions and contributions? Okay.
Yes, just before we go, I don't know, there's it's on the tip of my tongue, but I don't know if anybody can remember it. The name of that endonasal flap. It's there's a famous person. Does anybody know that there's some name, Hazadi, something like that? Does anybody know the name of the flap? I remember in dissection class, there's a name of the name of that flap. Okay, I'll look for it. It's something like Hazadi or something like that.
Haddad?
Excuse me?
Haddad.
Haddad.
Is it not the predicate as a septal flap?
Yeah. Yes. Thank you. Okay, thank you. Okay. Oh no, thank you, everyone. Yes, I think as we said, we can close. Thank you.
Mike, what did you say?
Thank you very much. I said thank you, everybody. I'm just appreciating everybody. It's a very nice.
Yes.
I would like to be part of this every night, please. It's helping to improve my knowledge base. Yeah, thank you very much.
Thank you.
And I think day by day, as much as we are discussing more information. Before we were just restricted to one thing. Now I think everybody is contributing more and more from the other books, from the other places. So it's increasing.
Yeah.
Definitely.
Good night, everyone. Have a good evening. Bye.
Okay, thank you, everyone. Good night to you all.